Thank you. Thank you, everyone. My name is Syed Haider. I'm a PGY3 resident at Rutgers NJMS, and today I'll be presenting about analysis of racial disparities in fundoplication surgery. I have no disclosures to announce, and I would like to thank SAGES for giving me opportunity to present about this topic. So fundoplication is a common anti-reflux procedure that's performed for a number of reasons, but one of the majority reasons it's performed is GERD, gastroesophageal reflux disease. Over the course of last 10, 20 years, laparoscopic fundoplication has become standard of choice for these procedures. And major reasons for those are predominantly related to the outcomes because patients have lower respiratory complications, have a shorter length of stay, lower respiratory complications, and that has led to increase in the fundoplication performed laparoscopically. Over the course of a few years now, robotic procedures are something that has gained more prominence than laparoscopic. The literature in this particular disease process for GERD in particular shows a racial distribution of the disease prevalent up to 43% for the black patients, 34% for the white, and 23% for the other races. However, things that intrigued us the most was the data was scarce regarding the minimally invasive approach to the GERD disease and fundoplication in particular. So we predominantly decided to investigate that to see if there was differences in the operative approach to acid reflux and whether there was a difference between the blacks and white in particular regarding the access to minimally invasive approach. Just for our methods and concern, we used the NISQIP database from 2012 to 2019, actually, so the slide next will be updated. And we used analysis using the preoperative variable, length of stay, postoperative complication, and used univariate analysis and propensity score matching for our analysis in the study. Results from 2010 to 2019 were investigated, and we identified a total of 12,000 fundoplication cases that were identified in the NISQIP database. And out of those, 12,000 were predominantly self-identified white patients, Caucasian patients, and 727 were the black patients. One major thing to point out is the reason we chose these two populations was predominantly because of the reporting from the NISQIP database. These are the two predominant populations whose numbers are well represented. And then we further analyzed this by propensity score matching with a 4-to-1 algorithm. And the whole point of doing propensity score matching was to balance these patient population by their preoperative variables and make them similar to one another. As one of my mentors always says, it's a poor man's way of doing clinical approach by doing this retrospective analysis. So for our, my apologies about the results being smaller, but I'll summarize what this table essentially is showing is we basically looked at the variable that was most intriguing to us was to see the open approach to surgery between the black and white patients, and to further analyze whether black and white patients had similar or different access to minimally invasive approach. And what we found out that the black patients do have higher incidence of open approach to fundoplication, but these results were not statistically significant. Then we further analyzed our study using the propensity score matching, and when we do 4-to-1 propensity score matching and try to analyze if there was a difference in operative approach between the two populations, we identified no association between the two with our p-value of 0.707, signifying that in terms of the access question, both the populations had equal access or similar access to fundoplication procedure, even though black patients undergo more open procedures. Once we had identified that there was no differences in access to the minimally invasive approach, our second major question that we wanted to address was there any differences between the two populations regarding their postoperative outcomes? And the 5 things that we analyzed, or 6 things we analyzed, were the complication rate, whether it was minor and severe. Minor we defined as something that was a UTI, pneumonia, or a longer length of stay. Severe was as bad as mortality, but longer hospitalization population, say, resulting in sepsis and deep infections and all those things. And we examined the mortality rate and the readmission rate and reoperation rates between the two. And between the two populations, we identified that Black patients had higher incidence of minor, severe, any complications, and higher rates of mortality between the two. This was not stratified by the operative approach. And this leads us to bigger discussion of while the axis between the two populations was not insignificant, it's important to address and understand the surgical disparities in the postoperative outcomes, in particularly regarding the fundoplication procedures. And I do believe that the reasons for disparities in the postoperative outcomes are multifactorial. So I'll start by saying one of the most important things in fundoplication surgery is a patient selection. And I think we use NISQUIP database, so it doesn't really tell us about the insurance status, the geographic status. So patient variable, that variable in itself of patient selection is something that's difficult to control in this population. The second thing that we wanted to one of the things to bring up is to assess the patient's preoperative variables. So literature shows that nutritional status being different results in different postoperative outcomes. And literature shows that Black patients in colorectal surgery in particular have lower albumin status and poor nutritional status that can result in higher complications in their postoperative outcomes. So that's something that could explain some of the postoperative outcome differences that we are seeing here. Lastly, patient education becomes significantly important in these procedures where patients have to follow up postoperatively with their surgeon for a duration of time. And I think that could explain partially a little bit of differences in our outcomes. And last but not the most, and one of the most important things is implicit bias in our training, something that we all want to rectify. But studies have shown that differences in sort of clinical variables or decision-making results to a greater differences or interaction between the patient and their physician that results in greater postoperative outcomes, greater postoperative complications. And Black patients in literature has shown that they do have higher incidence of complications secondary to implicit bias that they notice from different physicians. So in our conclusion, race is, we conclude that it's an independent predictor of postoperative complication, but an operative approach was not the result of differences in our fundoplication surgery in particular. I would like to thank SAGES and all my mentors and our program itself for giving me the platform to study this. Thank you. I'll take questions.